Well, thank you. So could you go to the next slide, please? So Cope Health Solutions is a organization. They were established in 1995. They have offices in 4 states, California, Texas, New York, and we're opening up an office in Washington. They have 90+ staff. They're experienced in increasing education of the public, and we have experienced that by doing that. We also increase engagement, which then increases success of the project implementation. So with the, can you go to the next slide? COPE has extensive line of healthcare consulting and workforce development services. You can see our service lines. Basically, the organization is helping transform the medical delivery system into a health and population health delivery system. And on the next slide, Mallory is going to lead off and speak about the 9 steps and lessons of the waiver cycle implemented. And this is really for focusing on Initiative 1 of the 1115 waiver for the Washington State. Thanks.
Hi, this is Mallory Johnson-Cole again. So this slide is just showing that over the course of the last 6 years, COPE has extensive waiver experience both in the California, Texas, New York, and hopefully Washington areas. This lists a few of the organizations that we've worked with, and it's hard to sum up all of the work that we've done with these different organizations in one slide. But to say that we've been involved in the waivers from pre-implementation, pre-approval, through implementation, and into renewal in a number of states would show the continuum that we've participated in over the course of the last few years with our clients. So moving on into 1115 Medicaid waivers, I'd just like to take a moment to remind everyone that 1115 Medicaid waivers are not always district waivers. They can come in many shapes and sizes. This program focuses on the district-like waivers that have become commonplace in the last few years. But essentially an 1115 waiver demonstration is a demonstration program that enables organizations or states to try and change something a part of their delivery system. The district waivers, and currently the CMS ideal state, is driving towards the triple aim through collaboration. So recent waivers has focused on the collaboration between providers and MCOs, working towards transformation and sustainability through care coordination, the development of integrated delivery systems, or organizations across the care continuum who are focused on improved outcomes and high performance. The sustainability piece is becoming more and more important as the waivers are introduced in new states. CMS is very focused on understanding how states and organizations will be able to sustain in the new structure of value-based payments. Some high-level themes and common program elements from district waivers that we've seen is collaboration is key. They're leaning more towards forming regional structures. This was not something that took place in California, but we've seen in New York, Texas, and likely Washington. They require federal, state, local accountability, utilizing the intergovernmental transfer process to draw down the federal share of funds. Each plan requires the participation of providers to be identified, and participation in 1115 waiver programs is voluntary. Everything will need to relate back to a community needs assessment, and the most important thing to understand is that everything in these 1115 waivers is driven through performance achievement. So the detailed milestones and metrics to achievement set the expectations for moving forward. We're having a little bit of trouble showing the next slide, so I'm going to talk through it and see if we can't get it to come up anyway, just so we can be respectful of time. This slide is to show the cycle of the waiver implementation for non-regionally approached waivers, such as California and Texas. The cycle here is that these organizations would assess community needs and make project selection walkthrough plan approval, and then their project planning and operational support. Once they've achieved this, they'll work through their performance on process milestones and clinical metrics, participate in state-required reporting, and then the states will review and approve their payments based on their performance. This cycle repeats over and over because they have to continually refine their approach to project implementation to make sure that they are participating at the level of achievement necessary to draw down their funds. In waivers such as New York and what we believe the Washington waiver will look like, the cycle is a little bit more complex in the sense that because the programs are regionally based and they require the participation of providers across the care continuum, there's a little bit more complexity in the cycle. So once the regions are developed from a geographic standpoint, the regions will work together to assess community needs and select their projects. The plans will go through a CMS approval and valuation to understand what is the maximum earning potential of the regional designation. They'll go through project planning and determine what operational support needs they will require in order to implement the project. There they will likely need to develop performance-based provider contracts for the organizations participating in this regional area. In New York, the PPS, or the Performing Provider System leads, have developed performance-based contracts with all of the organizations that are participating in the PPS. Similar to Washington, those would be those that are participating in the ACHs. Then the organizations would achieve their performance on defined process milestones and clinical metrics. Regional providers will need to report to the lead in order for the lead to report to the state, where then the approval of performance will take place, and then the funds will flow back through the lead then to the providers based on contracts. That is the structure in New York. We anticipate that something similar will happen in Washington as the waiver is further developed. So to tie it all together, what will ACHs need to know based on the waiver requirements and CMS aims? The network development will determine the geographic focus and capabilities for providers and project implementation, which has been occurring over the last couple of years. The community needs will drive the project selection and ultimately determine what requirements for performance that each ACH will need to implement. The partners will implement projects across the care continuum based on their defined role, based on their current core competencies and focus in the healthcare industry. Payment to the ACH and the individual organizations will be earned through successful performance in the implementation of project core components, and eventually the clinical outcomes that are tied to these will be linked to the value-based payment and structure goals. And it's very important to remember that waiver programs are not grants, and the funds are earned through successful reporting and achievement of the defined process and clinical outcomes.
So this next section is titled Washington Waiver, What We Know, but it's probably more accurately titled What We Don't Know, just because the state is still negotiating a lot of the rules with CMS. We know that we've had an agreement in principle with CMS very recently, so CMS has agreed to the waiver principles and the waiver concepts and the funding level, which is $1.5 billion in federal funding. But there's still a lot that needs to be determined, specifically the standard terms and conditions, and then the program funding and mechanics protocols. And this is not a unique position for states. We've been in Texas, New York, and California, and in all of those states, or most of them, there was a year zero, where there was planning and negotiating with CMS. But we don't have a year zero in Washington, so there's still a lot that needs to be figured out. But just know that this is par for the course. There's some time where they want us to plan, but the rules haven't been finalized. And you're kind of building the plane as you fly it, as we like to say. So that's to be expected. So the Washington Waiver high-level goals, we've listed them here. These are listed in all of the waiver documents, so it's nothing new. And if you go to the next slide, you'll see that really one of the overarching long-term goals of this waiver is to move providers towards value-based purchasing. And in the middle of this diagram, you'll see that the goal is by 2021 to be at 90% VBP statewide. And so that's on track with the New York goal as well, about the same time period. So this definitely will come up more and more, and that's the ultimate context for this district program. So like I mentioned, there's just a lot that we don't know, and these are a lot of the operational elements that we as a company have worked to implement, and these are things that we just wanted to point out that we don't know, and that's okay, but we'll have to start thinking about them, and Mallory and I will talk a little bit about them in the next section. But the ones I wanted to point out were the toolkit of the projects. We don't know what projects will be on the menu, in that's obviously the main element of this whole program, which projects you will implement. We don't know what the clinical metrics will be. So as Mallory mentioned, this is an incentive program, not a grant program. So ACHs will be rewarded funds based on achieving those metrics. And it's hard to plan for improving those metrics if we don't know what they'll be. That's true, but I think we can still work on defining our networks and setting ourselves up for success as these things get defined. And then lastly, the payment/funds flow to providers. We don't know how prescriptive the state will be. They might be very prescriptive about how that works and what percentages flow down, or they may not be at all. And so we'll have to prepare for both scenarios. All right, so this next section is really the meat of our presentation, and it's the waiver cycle. And this tracks with that regional cycle that Mallory spoke to before, the one that is in New York and that we think will be the way that Washington implements it with the regional structures and the regional integrated delivery system. So these are the same steps that she walked through in that earlier colorful diagram.
So we're going to dive into each of these areas over the course of the next few slides. So the thing that we'd like to focus here is the development of regions. This is where we will need to develop clearly articulated roles for organizations in their clearly articulate the role for organizations while they implement their projects. We'll need to understand the equitable fund flow distribution based on their impact as defined by data, and project implementation based on the outcome improvement. We'll need to currently limited connectivity to other providers, and we'll need to understand all of the organization's ability to document information and be able to share that with the performance leads. And we'll need to understand everyone's current service and volume levels, and if they're able to expand their current capacity in order to participate in these waiver projects. So the ACHs will be required to select and implement projects across the care continuum that meet the needs of their local geography, developing likely an integrated delivery system that will focus on eliminating health disparities and increasing health equity. It will be important to include organizations that focus on the social determinants of health and clearly defining a role for them. We know that providers across the care continuum, including local governments and tribes, philanthropic groups, health and long-term care providers, among others, will be able to participate in the waiver in Washington. And based on their core strengths and capabilities, the needs of the area, and the projects that are available, the ACHs will select these projects and further develop and refine their region and network.
So the next thing that we always want to highlight is the need to tie this to community needs. And so in past waivers in other states, this has been a very specific requirement. The state and CMS require that as part of the waiver application, a community needs assessment is completed. and it is used to very tangibly, very directly tie to project selection. I know that the ACHs in Washington have done some needs assessments before, so I don't know if the state will allow us to repurpose that or whether they would want you to do a totally new community health needs assessment specifically for this application. So that's just something to potentially prepare for. And aside from just the requirement of CMS wanting the CNA and wanting it to tie back to the health needs, it really is a good exercise in terms of project selection. We've seen providers choose projects that they thought were good projects, but they really weren't able to tie it back to the community need. And then when they started to implement it, they were actually finding they weren't seeing the volumes or the community response that they thought they were going to get. And so that just emphasizes the need to make sure that this is a project that really is needed in the community, just to make sure that the outcomes that you are looking for will happen. And so I just wanted to speak a little bit about the target population. So in other states, the target population has included uninsured. I don't know if Washington will or will not, but even if the waiver does not specifically target the uninsured in addition to Medicaid, it's something to consider incorporating into your project, this population, because as we all know, there's a lot of churn between the Medicaid and uninsured population. So by targeting both, you're really going to see the impact that you want in your community. And then this slide is just an example of how a former client has used the community needs identification process. And I really like step 3, where they did an analysis of ED visits for local hospitals. And they found that a third of dental diagnoses that were treated could have been dealt with in the primary care setting. So using data is really key. And then this slide is more about the project selection. And there's not much to say about this until we really have the project menu. But we've seen different sizes of menus in different states. In Texas, it was 120 projects, maybe 200 project options. And now in California, with their most recent renewal, it was 18 projects to choose from. So I would anticipate a smaller menu, just because I feel that CMS is working to streamline and standardize projects rather than be more expansive.
Another important element to the waiver cycle is developing your plan and understanding its valuation and obtaining approval from CMS. So as Natalie mentioned, the menu of projects that you will choose from will likely be a more limited menu than we've seen in Texas and the first California waiver. This is important, and the reason that CMS has narrowed the menu, as Natalie mentioned, is so that they can manage the project implementation and the approval process going forward. ACHs will need to complete a state-defined application, which sometimes there's ample time given to do this, and sometimes there is very little time to do this. So the best advice we can give is to be prepared for the worst and anticipate that you might have to move quickly to obtain all of the elements required in the plan. And what we've also seen is that these tend to be an iterative process. In most states, there's a couple of rounds of either what the application looks like or what CMS or the state is looking for in terms of it to be completed. Sometimes the quality of the plan is important in determining the overall funding that an ACH area will get. In New York, we saw the plans went through a competitive valuation and scoring process. The score that organizations received on the application was a factor in determining the amount of funds that that performing provider system received. That was not the case in Texas and California, so we'll be interested to see what CMS ultimately determines for the Washington waiver and the standard terms and conditions. The plans typically include narratives and a rationale for selecting the projects, as well as a timeline for the project implementation. Some states have given a couple of years to ramp up projects before starting to measure clinical outcomes, and others have had to start measuring clinical outcomes from the outset. So it will just depend on what CMS negotiates with the state.
So we've been talking a lot about the plan application and selecting your projects, and for Washington that will definitely be the immediate focus. But once we have our plans submitted and we have the plans approved, we have to dive into project planning and operational support for these intense projects, and that will be the core of the work for the next 4 years, which is supporting these projects, launching these projects, and doing it in a sustainable way that doesn't burn out staff, because the reporting cycle can be intense, especially in New York. It's once a quarter. So just setting it up to be a sustainable project management office is important. So one thing that we've seen is the most successful is that organizations set up a dedicated PMO, which stands for Project Management Office, a dedicated PMO for DSRIP and for the waiver. And it really depends on the size of the program. Some providers have up to 20 projects in Texas, so they really need a really big, robust PMO with multiple staff members. And then some providers in California have a smaller selection of projects, so they just need a smaller PMO. And New York is somewhere in between. But definitely look at the work and the type of transformation that these projects are undergoing and determine the best size of the PMO. We've seen anywhere from 5 to 20 to 40 people in a PMO. And so there are just some things that we wanted to highlight in terms of what to think about as you continue to implement and operationalize your project. One is know your population. So do you have good data on your population? Can you track what's happening with them? So then when you implement these projects, you know what's working and what's not working. And that ties in with get good data. You always want to identify your resource needs early. So a lot of what we do in New York is process mapping for each of the projects. So we'll go through the project goal, the project intervention, we'll map out the process along the care continuum, and then we'll say we need a navigator here, and then we need a data analyst here. And then once you map that out, you can identify which FTE you need, which resources you need. And then as you guys will start looking at creating networks and creating the integrated delivery systems, which you're doing with your ACHs already, but assessing the partner capabilities and what they can bring to the table as far as creating the change for these projects.
One item here is, again, as we mentioned earlier, we don't know the final structure of the Washington Standard Terms and Conditions. So this step may look very different based on the requirements that Washington inputs. But what we saw in New York was a need to develop performance-based provider contracts that the lead executed with the different organizations that made up the performing provider system, or in the case of Washington, an ACH. What will be important for the leads to understand is the readiness of their providers for performance-based contracting, and what types of contracts will enable the ACH to be successful in achieving their regional milestones and earning the funds allocated to the ACH.
So as we've mentioned throughout this presentation, money from the waiver is given for achieving the clinical metrics. And so a lot of this will be gathering data on a regular basis so you can monitor your performance and ensure that when the end of the year comes, or when that reporting time comes, you feel confident in the number that you've achieved for whatever outcome. And this will have to be something that you do the first year, and then you'll improve it the second year and improve it the third year. It's a constant iteration of improving the data collection and the tracking of the clinical metrics. And then another thing that I would like to point out is definitely expect there to be revisions on the measure specifications. So you might receive your measure specs early on, but the state will continue to iterate them, so be prepared for those changes. And then coming up with a good reporting structure with your providers will be important as well.
Dive a little bit more into the reporting strategy with your providers. The ACH as a whole will be required to report to the state and CMS at a minimum annually. We've seen semi-annually and quarterly in other states. But in the case of regionally implemented programs, it's important for the regional providers to report their achievement and their defined roles to the lead so that they can then further report to the state. We've seen other things that ACHs may need to consider in the future, and some tips and tricks that organizations may need to consider as they're looking to understand their role in implementing projects within their organization. It will be important for the lead to define what it is that they're looking for and putting that down on paper so that organizations can understand their expectations. Organizations may need to consider having a person that is accountable for their reporting to the lead, making sure that someone is paying attention to it throughout the year in order for documentation to be as healthy as it could be at the end of the reporting period. High quality in the documentation should be an expectation for all providers and for the ACH so that they can easily tell the story of their success to CMS and have that available for audits when they do occur. And through successful reporting, it enables the opportunity to do some continuous quality improvements such as PDSA cycles to continually adapt and improve this reporting process, looking for ways to make it more efficient and effective as the program continues to develop.
So if this looks like it looks in other states, the lead or the ACH will be the one ultimately responsible for reporting to the state, who will approve achievement of the district milestones and the district outcomes. So like Mallory mentioned, the reporting is subject to an audit at any time during the waiver period. So ensure that whatever you report you store in a location that can be accessed maybe even years later. And I've seen them even go in and say, you reported this patient. Can you go into the EMR and show me this patient? So it can be that intense. I don't know if it will be, but I've seen it. And then if at any time you're audited and it's found that the documentation is not there or the achievement was not accurate, CMS usually reserves the right to recoup payment at any time. So that's always something to be aware of.
Organizations generally are wanting to know how that the funds flow down to providers. What we've seen in regionally based programs such as New York, the collective achievement of the performing provider system was tied to the PPS earning the payment. So what this slide shows is, let's say there are 6 hospitals that are being measured in the PPS on their ability to, as a whole, reduce 30-day readmissions. And we can see that if the goal is 10% improvement, some organizations achieved more than 10%, some organizations achieved right at 10%, and some did less. However, the collective improvement of the providers in the system was 10%, enabling the PPS to earn their money. From there, it was up to the lead, based on their performance-based contracts, to flow the funds down to providers. So the related performance is up to the lead to then determine how much money each organization got. Again, that's a very New York-specific example. In Texas, organizations earned their funds directly, and in California it's the same, and we don't ultimately know what Washington will hold.
So this slide is essentially just to say that whatever you do in the first couple of years, do it again and iterate and learn how to do it better. That's really what this is. It's a demonstration. So CMS and the state are fully expecting us to learn each time we report, each year. And so feel free to make mistakes, but learn from them and figure out how to better do the projects and better improve the community through this process.
So yeah, that ends our regional implementation waiver cycle. So Leah, if you'd like to open up for questions, we can take them at this time.
Absolutely. So we do have some questions from the audience, and we welcome you to continue submitting questions as we go through here. So our first question, Natalie and Mallory, is regarding the definition of providers. Are the providers always framed as clinicians and clinical institutions? In an earlier slide, we addressed the social determinants of health, but the projects appear to be clinical around the PCPs, behavioral health integration, and post-discharge care.
That's a great question. Providers is generally a catch-all term to just use one word to describe waiver participants, and providers have been different in each state. So in California, the participating providers are only hospital systems and those that they work with in their ambulatory setting. In Texas, the providers were all clinical in nature in the sense that they were hospitals, physician groups affiliated with an academic health science center, mental health agencies, public health departments, and hospitals across the state. In New York, the provider definition expanded to include those across the care continuum, including SNFs and community-based organizations, FQHCs, hospitals, primary care organizations. And in New York, or in Washington, we anticipate the providers to be a catch-all, again, in terms of those that are participating in the waiver. So we've seen that eligible organizations will also include tribes, tribal governments, providers across the care continuum that may be community-based organizations or FQHCs. So provider does not necessarily mean a physician or a nurse practitioner or a dentist or a clinical provider in that sense. It's a term that is used really just to describe the waiver participant.
Thank you. We spoke a lot about clinical outcomes in the presentation today. Can you both speak to population health outcomes, more on the social determinants of health, those non-clinical health and well-being projects, especially in terms of what kind of metrics may or may not be involved on the social determinants side of health?
Sure, that's a great question. And I think that's a really good point, which is how do you measure and how do you capture these more new social determinants of health and community population health measures. What we've seen so far is that the metrics are still very clinically based, but you will be measuring them in a larger population. So I think that gets to the population health aspect of it. So you'll be measuring diabetes outcomes like HbA1c, depression screening for diabetes patients, but you'll be measuring it for a whole swath of Medicaid patients. And so that's really the population aspect. But we have seen that they are still very much clinically oriented around these status measures that CMS is interested in, and that they use measures from measure stewards. So they'll use measures from NCQA, HEDIS, ARC. So it'll be the measures that you're familiar with most likely. And then in your reporting, they do ask you to add narrative about other ways that you've been measuring the population, but in terms of being able to standardize the measures, they use the ones that are already established. From what we've seen, obviously Washington could go any which direction with this.
Building on that last question, we have quite a few folks on the line today who participate or help to run CBOs, community-based organizations. So if you both could speak to how CBOs participate in the waiver, a little bit of a deeper dive on their role and how they can best prepare for their participation.
Sure. So I'm going to draw on my experience in New York, as that was the first state to really allow community-based organizations to participate in the waiver. So what we have seen here is that the lead that is ultimately responsible for the performance of the performing provider system and all of the providers in the area has to define the role for each provider in the organizations that, or in the projects that the organizations have selected to participate in. So if you are implementing a care transitions process, you know, managing the patient from an inpatient stay, preparing them to be back in the community, and through that you find that they lack transportation and food needs, and you have community-based organizations that excel in that. The lead would be responsible for defining those organizations' role in implementing this project, ensuring that policies and procedures are there across organizations to work together, that organizations know and understand their resources. It's important for the community-based organizations to be able to articulate what their strengths and weaknesses are as an organization, what their core competency is, their ability to expand their current volume. One of the challenges that we saw in New York is community-based organizations wanted to participate and they signed up in projects, and when the role was defined for them, it became clear that they didn't have the ability to currently expand with their resources. So it was hard for them to implement their defined role in these projects. It's also important for them to understand that funds flow, at least in New York, initially based on attributed life members, and we understand that community-based organizations don't necessarily carry attributed life to them. So what we did in New York was we give them basically what we thought their accountable lives would be in order to plug them into the funds flow evaluation. So we've had to work with community-based organizations to be patient as we look for data that would be able to truly articulate the value that they're bringing into the successful implementation of these projects and accurately flow funds down to them for their performance.
Mallory, is it possible for you to give an example of that type of relationship between the CBO and the lead organization, maybe from New York or Texas, and tell the audience a little bit what that experience was like?
You know, Leah, outside of a very general articulating a role of a type of community-based organization to a specific project, I don't necessarily have a concrete example. The CBO strategy in New York has been a very important topic, typically taking a whole work stream in and of itself to understand how do we continually build better relationships with the community-based organizations, how do we define their role, and how do we equitably flow the funds down to them based on their performance. And typical clinical data is not always readily available for these organizations. So it's been an important thing in New York, but I don't know that I have a good example off the top of my head to answer that question.
Okay, well, our last question here from the audience is whether we'll be able to distribute the slides after the presentation today. So we'll be happy to do that either by request or in a follow-up email to the group. Mallory, Natalie, would you like to close us out with some remarks here?
No, just thank you to everyone for attending and listening. We were having some technical issues with the slides, so we apologize for any toggling back and forth. But like Leah said, we'll send them out afterwards for everyone to review. And, you know, we're just really looking forward to going on this journey with Washington. It's exciting, it's frustrating, it's long. 5 years has never felt so long, but it really does transform the community. We've seen this work, especially in Texas. So we're very excited about the principal agreement with CMS.